folks, we're going to go ahead and get started here.
Because there is a senior agency.
Thank you very much for joining us this afternoon for our Doctor is In program on pain management. So for those of you who haven't been to programs with us before, my name is David Griffith. I'm the Director of Programs and Outreach for the LGBT Elder Initiative. And the Doctor is In is a collaboration between the LGBT Elder Initiative and the Jefferson Center for Urban Health and the Jefferson Department of Family and Community Medicine. So we've been doing these monthly health programs for over a year now, having Jefferson geriatricians, geriatric and palliative care fellows come in to present to our community about topics that are relevant to healthy aging. So I'm very happy to bring up Dr. Matthew Murphy, who is a palliative care fellow here at Jefferson. This is his first Doctor's In program with us, so be nice. And please give a nice welcome to Dr. Murphy.
Yeah. Thank you, David. Thanks for having me. Also, a quick thank you to my boss, John Lee Antonio, for asking me to be here today. You've met some of my colleagues, Drs. Beth Collins, Bruce Reeves, and Mariana Cooperman, and they've told me that this is a very engaged group, a very engaged audience. You'll notice there's not a whole lot of slides up here today, which is a little unusual for me because, as John will tell you, I love making slides. But that's, again, because I hope this is a conversation. So thanks again for having me. Today's topic is going to be pain management, a very important topic in my opinion because every single person in this room, myself included, has experienced pain at some point in our lives. Now we're going to be talking a lot today about physical pain, i.e. I cut myself, I burned myself, I fell down, scraped my knee, whatever it might be. But that's to recognize that there are also other types of pain, certainly emotional pain. We've all experienced that at some point or another. Existential, spiritual pain. These are all things that tie in together that can affect our minds and bodies. So as we're talking about this topic today, I want you also to think about how mood might affect the physical manifestations of pain, and thinking about those other things that really I can't recommend a pill necessarily to help with, but just practicing mindfulness and other techniques that might help with overall pain. So my disclosure, I have no conflicts of interest to report for the following content. I'm not being paid by any pharmaceutical company. In fact, I'm not being paid at all, but I'm happy to be here. So thank you again. So acute pain, what is acute pain? Well, as we know, we can fall down, we can hurt ourselves, we can burn ourselves, and that's what we're talking about in the setting of acute pain, right? Most common causes being muscle strain or sprain, and again, those common injuries that I'm sure we've all experienced at one point or another. The mainstay of treatment for these types of injuries really are best supportive care. What I mean by that is if you cut yourself, you burn yourself, we're not necessarily talking about admitting you to the hospital, talking about those really, really strong pain medications and doing all kinds of advanced things. We're talking about common over-the-counter medications, some of which we're going to talk about in a few minutes, doing things like ice, heating pads. I'm probably not sharing anything groundbreaking with anybody in the room. We've all experienced these. Most of these injuries will heal with simply rest and time. It's important to note that we'll all experience acute pain, but what I really want to spend a little bit more time talking about today is chronic pain. What do we do when we're experiencing pain longer term? Do you have a question over here? I'm sorry. Oh, okay, perfect. Just making sure, no worries. So, chronic pain. This is very, very common. It affects 100 million people in the United States, responsible for 20% of all outpatient visits. So 1 out of 5 individuals who go see their healthcare providers, part of that visit will be chronic pain. It's responsible for 12% of all prescriptions, $100 billion every year in direct and indirect expenses related to it, i.e. medications, doctor's visits, missing work, all those things. And it's defined as a persistent pain for greater than 3 months, most days of the week for greater than 3 months. This was one thing that I wanted to have an audience response question, but if you feel comfortable raising your hand and sharing, you don't have to, by no means. But just a quick poll of the room, how many folks would say that you fall into that category, experiencing pain commonly, most days of the week for greater than 3 months? A fair number of hands up in the air, and that's not surprising, when you look at these numbers. we'll talk about the most commonly affected sites of the body, namely low back pain, knee pain, right? I'm seeing a lot of heads up and down nodding, right? So unfortunately, our bodies are, as best as they are designed to withstand the normal wear and tear of everyday living, things do break down, right? We start having cartilage wear in our knees. We start having loss of space of the bones in our back. Things start rubbing together, causing irritation. We're going to talk about some strategies to help with that. So this is a quick overview from the National Health and Nutrition Examination Survey, which was over 5 years, over 5 years polling, I think it was a few 100,000 people talking, who suffer from chronic pain, and what are those most common sites that are affected. We just mentioned some of them, but back pain is roughly 10% of those folks, and then you see the other percentages laid out here. The bottom line is this is common, and back pain is a very common complaint that we'll see in the outpatient office where people are seeking some relief. So I don't want to get too technical, but as a palliative care physician, I spend a lot of time taking care of folks with chronic pain, with pain that is comes in different flavors, if you will. It's caused by a couple of different things. Usually it's not just one thing that's causing somebody's pain. So I don't want to get too technical, but I want to spend a little time talking about what these terms mean in terms of the different types of pain. So when we think about pain as healthcare professionals, it comes in really two varieties, nociceptive and neuropathic pain. So we'll start with neuropathic pain. Neuropathic simply means that the cause of that pain comes from the nervous system, from nerves, from irritation of nerves. Examples of that might be, and some of you might experience this on a day-to-day basis, but some of that might be, I have diabetes. It's not very well controlled, unfortunately, despite my best efforts. I have tingling and burning in my feet, maybe in my hands. If anybody's ever had shingles, you know that shingles can be very painful. After you have shingles, you can have lingering pain in that part of the body where that rash was. These are examples of neuropathic pain. And we'll talk about some examples of medications we use targeted towards that type of pain specifically. The other type, yes, question?
For shingles, why is it that they have a cure for it now, and then the people that suffer from it still have lingering pain?
Mm-hmm. So the question is with regards to shingles, and if we have a cure for it, and what I think you're asking about is the vaccine for shingles, the shingles shot, why are people still affected by this type of pain? Great question. So anybody who's had the chicken pox, myself included, I was born in 1988. Sorry, everybody, I was born in 1988. And I had chicken pox. I had chicken pox when I was a baby. Just like I'm sure pretty much everybody in this room did. And if you have had chicken pox, that virus, right, what's called the varicella zoster virus, is laying dormant inside your body. No reason to be alarmed. It simply means that at some point, you may have an outbreak of what's called shingles, which is a, unfortunately, painful rash that comes in kind of blisters on one side of the body. It can be anywhere in your body, and there is a vaccine for it. There's also a chickenpox vaccine now, so young children now who get vaccinated for chickenpox typically will not get shingles. But to answer your question, there is a vaccine. In fact, there are two vaccines. There's a new vaccine that was just released. The FDA approved it almost 2 years ago. That has been found to be a far more effective shingles vaccine for older adults. So that is now out in the community, and we're able to protect people and hopefully reduce the chances that somebody gets shingles and therefore gets this type of pain. However, no vaccine is perfect. So I encourage everybody to have a conversation with your healthcare professional about the shingles shot. If it's right for you, then I'd recommend considering that. But unfortunately, this is still possible to acquire shingles.
Well, how about if you had an outbreak, you had shingles, then had an outbreak after it, can you still get something for it to lessen the chance for you to get it again or anything?
So having shingles,
it was down the middle of my face, and it looked like,
Mhm.
I'm not making a joke, it looked like a creature.
So-
Seriously, and my whole face like you said, came
One
right
side.
in the middle of my nose on the left side, and it's still like I touch it hard, I can still feel it.
Yeah. The hope is that with time, that pain gets better. But you're absolutely correct that for months and months and even longer, unfortunately, after having primary shingles, you can still have that lingering pain. And in a couple of slides, I'm going to talk about some medicines that we can use for that. Was there another question?
Is shingles more like rash type or more like blisters?
So it's what's called a vesicular rash. So it forms blisters on one side of the body, right? And that's very important. If it's on both sides, most likely not shingles that we're dealing with. Traditionally on one side of the body, doesn't cross over the midline, and it can be, again, very painful.
More blistering?
Yes, it's more blistering, and then they eventually crust over, and then they recede. And it's important. If anybody ever, I know some heads nodding, some folks have had shingles. It's important. That is contagious, so you want to be, if you are having a shingles outbreak, you do want to be cognizant of that and recognize that it certainly is contagious to others at the time. I'll take one more question, then I'll move on. Yep.
You said vesicular, so is that similar to it being like a virus and it also being similar to herpes as well as chickenpox, and it's chickenpox a virus technically?
Yes, so herpes zoster virus, varicella zoster virus, which is what causes shingles. These are all family of herpes virus, right? Herpes virus is a very large family of DNA viruses that infect humans. And they're very, very large viruses, and they do traditionally cause those vesicular rashes, which can be little fluid-filled blisters. In the case of herpes, right, that's typically either oral herpes or on the genitalia or the anal region. Varicella zoster, which causes shingles, can be on your face, it can be on your arm, your torso, your buttocks, legs, anywhere, really. But excellent point. All similar family of viruses. Great questions. See, I knew you guys were really, really engaged audience.
You ain't heard nothing yet.
I like this guy. It's great. So assessment. How do we assess pain? Pain is a unique component of the human condition. If I examine you in my examination room, I can ask you a bunch of questions about your pain, but I'm not experiencing your pain like you are. So it's a difficult thing to fully appreciate. I don't think I can ever fully appreciate someone's pain, but what I can tell you is I can empathize with you as somebody who's experienced pain as well, and my hope is that we can help you. The questions I would ask you if you saw me in the office or if you saw Dr. Lee Antonio in the office would be talking about the location of your pain. Does it radiate anywhere? What's the timing? Does it correlate with meals? Does it correlate with when you lie down flat at night? All kinds of interesting questions to try to figure out what's going on. We ask you to use descriptive terms. Is this sharp? Is it dull? Is it burning? Is it aching? What are the associated symptoms? Are you feeling nauseous and you're vomiting and you have a lot of belly pain? Then when you vomit, your pain gets better? That to me speaks a very different story than somebody who has elbow pain and plays tennis, as an example. How often, and perhaps the most important question that we ask and that I really care about is, how is this pain affecting your functional status? Is it impeding your ability to walk around and do your daily activities and the things that give you joy? And as part and parcel with that, does it impact your quality of life in a negative way? Right? Because that's what we're talking about. How can we help folks dealing with chronic pain and improve their quality of life? So I wanted to talk about a couple of common medications that we've all encountered, over-the-counter medications, prescription medications, and talk about some safety issues with these and how we can best take these medications safely. I'm going to start off with acetaminophen, which is trade name Tylenol. Very common medication that probably most of you have at home in your medicine cabinet. It's also, so it's used for mild to moderate pain, and it's also an excellent fever-reducing medication, what we call an antipyretic. It comes in 325, 500, and 650 milligram doses. The 650 is what you might hear as Tylenol extra strength. It's also exceedingly important. I wish I had a bullet point here, but I'm going to tell you now, and it's on camera, so everybody's heard it. Lots of over-the-counter medications like cold and flu remedies, decongestants, also contain Tylenol. So they may contain a cough suppressant, something to help break up your mucus and stop you from coughing, but it may also include Tylenol for aches and pains and to help if you're having a fever. That's important because we must limit the amount of Tylenol that we take each day. Current recommendations cap the amount of Tylenol that you should take over the counter at 3 grams, that's 3,000 milligrams daily. Now that's important because going over that commonly and taking lots and lots of Tylenol can cause damage to your liver, okay? So it's easy to see that if you're taking decongestant and you're also taking some Tylenol at the same time, it's very easy to then go over this 3 grams per day. So read the package inserts of everything that you're taking. Just because you got it over the counter and didn't have to go to the pharmacist does not mean that it's without harms, right? So that's what we're talking about. So always read the package inserts. Non-steroidals, what are called NSAIDs, another common class of medications that most of us probably have at home. Common examples in this class of medicines are Advil, which is ibuprofen, Aleve, which is also called naproxen, Celebrex, celecoxib, Toradol, which is an IV medicine that we sometimes use in the hospital, and then good old-fashioned aspirin, right? A lot of, show of hands, I mean, everybody's heard of a baby aspirin a day, or maybe you're taking a baby aspirin a day, 81 milligrams. Aspirin is the kind of parent drug, the archetype, the prototypical drug in this class. And these are very potent anti-inflammatory medicines. They're good for arthritic type pain, toothache, headache, muscle sprains. Again, I just harped on Tylenol, but I'll say the same thing about all of the medications in this class. You really do have to read the package inserts, okay? Only take additional doses after you discuss with your physician, because taking too much can cause kidney damage, can cause heart damage, and increases your risk of bleeding. At normal doses that we're all used to seeing and taking, not a problem. But if you're finding yourself using a lot of these medicines, it's something to think about. Pick up the phone and talk to your doctor. Yeah?
You didn't mention penicillin. Is that in like the same category as ibuprofen
Nope.
and naproxen?
Penicillin is an antibiotic.
Okay.
It's a very common old antibiotic that's been around for 60 years that we use for certain things. A lot of infections it doesn't work for, but for oral infections we do use a lot of penicillins. Yep, absolutely. Question?
I've been told as well that things like ibuprofen and Advil, they can lead to strokes. Not full-fledged necessarily all the time, because I've had miniature strokes because I've had juvenile diabetes for eons. And I'm still here. I'm like, yeah,
Good for you.
I've had little, I guess what you call it, I don't know, for TIA, as far as the miniature
Yeah,
strokes.
sure.
And with that, I didn't realize that Advil, I would pop it almost like candy because it was sweet.
Right.
And it would, cure headaches and back pain and stuff. I didn't know until I heard that it would do that I can't even really take it anymore.
Right.
Did you guys know that too, or is that just a rumor that I heard?
Yeah, so let me actually take a step back. I want to make sure that for the microphone and for the camera, everybody knows the questions that were asked. The first question I just addressed was regarding penicillin, and is that related to non-steroidal anti-inflammatory drugs, which we're talking about now? The short answer is no, it's not. Penicillin is an antibiotic that's commonly used for oral infections and other types of infections. The second question was the risk of taking these NSAIDs, these non-steroidal drugs, and the risk of stroke. Absolutely, you're correct. There is a risk of causing not just cardiovascular damage, but what we call cerebrovascular damage. So damage to the blood vessels in your brain, and certainly an increased risk of bleeding. Stroke comes in 2 varieties: ischemic stroke, which is a clot, right? And then hemorrhagic stroke, which is bleeding into the brain. Certainly, taking lots and lots and lots of these medicines can increase your risk of bleeding and increase your risk of stroke.
I only heard about the ibuprofen/Advil situation that caused it. I didn't know about naproxen and
Yeah.
celecoxib.
Yeah, so ibuprofen is probably the most common alongside aspirin of what you're going to be seeing out there. Most commonly, it's in a 200 milligram tablet, okay? So the package insert, I think for Advil, as an example, says take 1 to 2 tabs every 6 hours as needed for mild to moderate pain. If you follow those examples, for most folks, as long as you don't already have kidney damage at baseline, right? So if you have kidney damage at baseline, or if you're on dialysis, you should avoid these medications, okay? If you have an increased risk of bleeding because you're on blood thinners, or you've had major bleeding before, you should be very careful about taking these medicines. Those are conversations that you definitely want to have with your physician. Question?
Yeah, there was recently sort of one of those breaking news on TV things saying, stop taking those baby aspirins. It's been all over. So
Correct.
I was thinking one at night, just,
Correct.
I thought it was helpful. Now I don't.
Yeah.
So you don't know what to do after.
Right, so the question is with regard to the latest guidelines for baby aspirin use for what we call primary prevention of cardiovascular disease. This has been a controversial topic. So this year at the American College of Cardiology meeting, there was some new literature that was published that showed basically a change in recommendation for people who are not at a high risk for cardiovascular disease, right? That being said, guidelines take time to kind of settle out into the community and for everybody to kind of start following those guidelines. I would say if you're already taking a baby aspirin, right, for primary heart health, have a conversation with your doctor. Say, hey, I heard on the news that there's some new information coming out. Am I in the group of people that should still be taking this, or should I think about maybe ditching the aspirin? So there have been some changes. It's a great point to make. I'm glad that you're kind of keeping up because this stuff is coming out into television and to print. So that's great that you're being aware of that. Question?
I asked my doctor the same thing because I take the aspirin every day for a couple of years. I still take it. And not because I was HIV positive, because I'm diabetic, and that's part of the heart. I don't have no heart complications, but that's part of diabetic that you take the aspirin.
Right. So people with diabetes are at increased risk of heart disease. And some of those folks, like yourself, maybe the recommendation is after having a conversation with their doctor, should I be taking this aspirin? So this is definitely not a one-size-fits-all medication, right? But what I will tell you, the take-home point from this class is, if you have any of those medical conditions like kidney failure or heart failure or predisposition to bleeding because you've had significant bleeding in the past, I'd recommend that you stay away from these medicines until you have a really thoughtful conversation. Nerve pain. We talked about neuropathic pain earlier. I just wanted to include a couple of examples. So we talked about chronic nerve type pain, especially in the hands and feet, what we call glove and stocking distribution. It's an apt name. Causes can be diabetes, I mentioned that, medications, especially chemotherapy. Certain chemotherapies that we use in folks who have cancer can cause very bad tingling and pain in the extremities. We mentioned shingles. And then the two medications, just two of the medications that we most commonly prescribe to folks with these types of pain are Neurontin, which is also called gabapentin, and Lyrica, which is also called pregabalin. You've probably seen commercials for Lyrica on television. These are medicines that take time to start showing benefit, usually a month and a half on a real dose to see if there's any type of significant improvement in your pain. We have to be very cautious with using these medicines, again, in folks who have kidney problems. They can also be very sedating. So when I start somebody on, say, Neurontin, gabapentin, I tell them we're going to start low and go slow. We're going to start you at bedtime by taking this. Maybe it helps you fall asleep a little bit. That's not necessarily why we're using it, but we'll take it. We'll take it as an extra benefit. So these are medicines that you are going to see. Question here, yeah.
I had shingles before.
Okay.
I had them on my back.
Okay. I'm sorry.
It wasn't on one side. It was on my back.
Mm-hmm.
In the middle of my back.
It was in the middle of your back. So was it on one side? I mean, was it, even though you said it was in the middle of your back, was it technically just a little bit on this side?
No, it was in the middle back. In the middle of my back.
It's possible, right? It's exceedingly uncommon, I will say that it would be on both sides. The textbook answer is that shingles is only on one side of your body, just because of the way that the virus lays dormant in your body. Sometimes people can have what's called disseminated zoster, where it can affect what we call dermatomes, different parts of the body. So on both sides. But I will say that the vast majority of the time, one side of the body. But thank you for sharing that point.
I was going to ask you, with nerve pain, I know that you had listed something up there that was talking about inflammatory. With nerve pain, I have edema that's from eating too much salt, not anything with my heart. could I take something when I have my feet swollen out, and would that be similar to being,
Yeah. Let me go back, because
turmeric to go ahead and ease the nerve pain as well as any inflammatory situations?
so the question is about edema, which is the clinical word for swelling, and how that can affect nerve pain, what we call neuropathic pain. I'm going to answer that question. I also want to take a step back to the slide because I realized I jumped ahead off of it. When we think about those the bottom 3 bullet points, i.e. musculoskeletal, inflammatory, and visceral pain, okay? Musculoskeletal is exactly what it sounds like. Muscles, bones, tendons, all that stuff. Strain, sprain, injury. We've all had it. Inflammatory. When we have an injury, our body is very adept at creating good inflammation to help blood flow get to that part of the body that's injured, because blood flow carries the necessary oxygen and nutrients to help the body heal in that part of, in the injured site. Makes perfect sense. Visceral pain is deep pain, which is related to the organs in our body. So if something is pressing on a nerve or an organ in our body, like edema, swelling, or like a tumor if somebody has cancer, anything that's pressing on a part of the body that's really not supposed to be there, you can have a pain response from that. Okay. So I wanted to touch on that because your question is referring to really what I just said, something pushing on something that's not supposed to be pushing on it. In your case, edema. Edema, which is swelling, can happen for a number of reasons. It can happen because of kidney problems, heart problems, liver problems, nutrition problems, salt, all those things. For most folks who have relatively normal kidney function and heart function, all that, and we all get swelling sometimes. Long day on your feet. I know if I have a long day in clinic or in the hospital, I mean, my boss, he cracks the whip. So I'm working hard. I come home and my feet are aching. I'm really swollen. It happens. Elevate your legs. Elevate your legs, right? Right? If you have a bad heart and you have heart failure, maybe you take a water pill, things like Lasix. If anybody's ever heard of that. Some people need medications to help remove fluid by urinating it off, right? But you're right that swelling can cause pain because that extra fluid is pushing on tissues. And it's just not meant to be there. With time, we may get used to that, but...
So visceral and anti-inflammatory, they're kind of one and the same with the nerve pain, or no?
I would say that, so our organs are highly innervated. There's lots of nerves there. So if there's something that's pushing on an organ or pushing on something, again, kind of getting back to the very beginning of the talk, I said, pain, although we try to compartmentalize it into different things, usually there's a couple of things going on at the same time, right? So there's often not a one-size-fits-all approach, like a medication I can give you to say, this is going to just fix everything. We have to get creative and think about, are there 2 or 3 different things going on here? Yeah.
So I can't take turmeric and fix the whole...
I can't tell you the evidence for turmeric.
Well, no, not for a tumor, but for...
No, for turmeric, but I'll tell you something. It's a great question. I'm glad you bring it up.
Okay.
I have a lot of folks I take care of ask me, Dr. Murphy, I'm taking X, Y, or Z that I read about on the internet or I saw on television. Is this okay? And I say, well, what is it? And they might not even know what the heck it is they're taking, and I don't like that. I say, bring the bottle in, let's look at it together, let's figure out what this is. Because you have to realize a lot of these products are not necessarily regulated by the Food and Drug Administration.
Right.
So I can't tell you necessarily what's in it, and I can't tell you, is it going to interact with other medicines you're taking, and is it going to help or not? But what I will say is, if I have some understanding of what it is, and I feel like it's not going to hurt you, and you think it's helping, I say, why not? As long as I feel that we have a conversation about it, and we think, hey, this is not going to cause you harm, that's my approach. And I will say that's been the approach of most of my colleagues. Right, John? Right, okay, great. So, steroids. I want to make sure we have enough time for questions at the end. But you guys are asking great questions as we're going. So, I want to include a slide about steroids because these are common medications that, again, most people have probably been on at one time or another. Examples are prednisone, Medrol dose packs, Decadron. I use a lot of that medication in folks I take care of. you should be using these medications cautiously. These are obviously prescription medications that have a lot of physiologic effects. They affect our bodies in several different ways. When you use them chronically, you take steroids by mouth in a pill, it tells your body, specifically your adrenal glands, which are little glands that sit on top of your kidneys, it tells them, hey, we have enough steroid right now. We're getting a lot of steroid. So adrenal glands, you don't have to make much of this right now. You don't have to make it. So you can develop what's called adrenal insufficiency, where your glands don't make the natural steroids that we have in our body, okay? So that's something to be wary of. So if you've ever been on steroids for a while, like folks who have asthma, maybe you've been on a prolonged course of steroids if you weren't feeling well, and your doctor might say, I want to taper these. We'll give you 40 milligrams a day for a week, and then we'll give you 30 milligrams a day for a week, and we're going to do it slowly. Because if we give you a lot of steroid and then take it away, that can cause problems. And then there's an increased risk of infection because these medicines suppress your immune system. So folks who are on a lot of steroids can develop infections, and they also cause osteoporosis, weakening of your bones, which if you're on a lot of steroids and you have a fall, you could unfortunately have a fracture. So these are all things that we're thinking about when we're using these medicines.
Dr. Murphy,
Yes?
what's the sense of taking it if it does all this stuff?
It's a great question, right? I think it was William Osler, who's the father of internal medicine, who said something. Maybe Dr. Crayer would know. I don't know. But Osler said, you know, the best medicine is basically avoiding physicians and avoiding medications as much as possible. So your point's a good one. These, you know, no medicine is without side effect. I will say that. There is not a drug that I can prescribe to any of you that is not necessarily going to carry a side effect. This is part of playing the game, unfortunately. We have to do the best we can with what we have and do the things thoughtfully that we can do to limit side effects. Steroids, when used in a thoughtful manner in a short course, a few days, can be very beneficial with minimal risk, okay? It's always a conversation you're having with your doctor because, again, these are all prescription medications. But it's a great point, right? So if you're on long-term steroids, make sure you're having conversations with your healthcare provider. Why am I taking these? Do we need to have a conversation about this? But you're right.
See, I just think, like, when I think about steroids, it's like, I look at people and say, oh, they must be on steroids because they're big and healthy and muscular and stuff like that. But I never even think of steroids to do all this other kind of stuff.
Yeah. So the steroids that you're thinking of for, you know, if you're packing on muscle like me, right? Just, you know, these are anabolic steroids, which really don't have medicinal use, okay?
Bad side effects too.
Bad side effects. And the steroids we're talking about are the same types of things that your body makes naturally, okay? I'm talking about using them thoughtfully. They can also cause elevated blood sugar. I mean, I haven't mentioned a laundry list of all the side effects, but they can have side effects. And they're activating, they can give you the jitters. So sometimes some folks we take care of, we'll give them some steroid and it gives them a little bit of pep, which is a good thing for them, depending on the person. But you might find if you're taking these, you're feeling yourself a little jittery, maybe not sleeping as well as you normally do. So again, in the outpatient setting, if you see me in clinic and I'm giving you a course of steroids, it's a short course. Usually days, maybe a little bit longer, but usually a very, very short course like days. Other questions?
Just one more.
I'll take it.
If you give people steroids, right, and then has it ever been like extra hard to get them off of them?
Usually going low and slow. Again, I use the word thoughtful a lot. If we do it thoughtfully, the vast majority of the times, yes, we can successfully get somebody off steroids with the understanding that they may again need them in the future, and we use the lowest dose that we possibly can, and then we taper them off equally as thoughtfully. So, but there are certainly people who have such bad illnesses that they're on steroids indefinitely for the rest of their lives.
Just to be alive.
We try not to do that, but for some folks, that's what we have to do.
Okay.
Question over here?
On any of these screens, steroids and anti-inflammatories, any of them affect on blood pressure?
Yeah, so NSAIDs, actually a lot of these medications can drive up your blood pressure. So NSAIDs definitely can cause hypertension. Can definitely cause hypertension. So these are things that we're being wary of, that we're monitoring. That would be the prototypical class of medicines that we'd be talking about today that can cause hypertension. Great question. Anything else before I move on? All right. So, opioids. Oh, I know. Uh-oh, right? This is bad. I use a lot of these medicines, my friends. As a palliative care physician, I take care of, unfortunately, very seriously ill patients, very seriously ill folks, a lot of whom are near the end of their life. And we use medications like this in the hospice setting, if you're familiar with hospice care, very often to make people comfortable and to allow them to be comfortable in their final hours and days of life. That being said, these are very common medications that we use in folks who are not in a palliative care or hospice setting. These are medications that we use in many folks who are community dwelling, such as yourselves. You might hear these medications called opiates or narcotic type pain medicines. We call them opioids in our field. Examples are up there for you: morphine, oxycodone, dilaudid, fentanyl. These are all terms that have kind of entered into the community lexicon in terms of we're seeing these more commonly. Obviously, heroin, which is an illegal drug, is an opiate, right? They're all in the same family of medicines. That's to say, when we use these medicines, they are not heroin. My hope is that whoever is prescribing these medicines is using them thoughtfully and really, really thinking about how to use them safely, because there is a right and a wrong way to use these medicines. And in the last 12 months, that's part of what I've been training to really become an expert in using these medicines. And hopefully my boss in the back of the room thinks that's the case, that I am an expert, so I hope so. These medicines are not indicated for the vast majority of folks with chronic pain. The exception being cancer-related pain. I take care of many patients who have very bad cancer and have very bad cancer-related pain, and opioids are very much the mainstay of treating those folks. Not always, but many of these persons receive these types of medicines to help control their pain and allow them to function. There is some role in these medications for acute post-surgical pain. So you go to Rothman Orthopedics and you have your hip replaced or you have your knee replaced. Your doctor may prescribe a very short course of these stronger pain medicines to help you while your body heals. And your body will heal. We're designed to.
Finish the rehab.
What's that?
And so you finish the rehab.
And so you finish the rehab. That's a great point, right? Because you got to build strength to try to improve that. And then I'm going to spend a minute talking about this last bullet point, and then I'll take the question. I see there's some questions floating around the room. When we think about, so a lot of people are worried about addiction when I start talking about these medicines. Doctor, I don't want to become addicted. I know somebody, I have a cousin, I have a friend. Most folks nowadays have somebody in their life, have first or secondhand knowledge of somebody who's struggled with addiction with these types of medicines, unfortunately, in this country. So there really is a difference between these three terms. Tolerance, right? At the basis of these medicines, you have a receptor in your body, and I give you a medication, I give you a drug. Drug binds the receptor, causes an effect in your body, okay? With tolerance, your body gets used to seeing that, okay? No longer are you getting the same physiologic effect. You were getting an effect with 5 milligrams of oxycodone, great. A while later, you're having worse pain despite 5 milligrams. We have to talk. Dependence, you're getting a drug, it's helping. All of a sudden, we're finding ourselves using increased doses of medications to get the same effects, right? So we're having a physiologic change based on the medication, and your body's really becoming dependent on it to get the same effect that we were getting. Addiction is, I have a receptor, I have a drug. It binds, it makes me feel really good. Makes me feel really good. I will do anything to get that feeling again, right? I will engage in behaviors maybe that are not good behaviors to try to get that. So there's a difference. Addiction is on the other end of the spectrum in terms of, you know, the willingness to go out and really do anything to get that same feeling, to get that above and beyond feeling, right? So I want you to know, if your doctor, if you see me, I can say this with certainty, right? But if you're having a conversation with your doctor about starting these medicines, it needs to be a real conversation and with a plan of what is the long-term plan. Is the plan to be on these briefly and then get off of them, as it should be, right? And what is that plan going to look like? Because this is a thing that a lot of folks I talk to are worried about. So the best advice I can give is have an open dialogue and have a conversation. Question.
No, I had whooping cough before. And
Wow.
I was taken to Mercy Hospital in West Philly.
Yeah.
They didn't tell me, number one, that I was diagnosed with it. Number two, they gave me something, I forgot the name of it, but it begins with a B. That was no opioid. I had no clue. I wasn't really in pain. It was just very annoying. I started to get like a little bit of a sore throat, but it wasn't so excruciating. I'm crying. They gave me this opioid, and they didn't even tell me, you have whooping cough. I don't remember the name, I wish I could, of that, so that I would know if whooping cough is something that could have gone ahead to become so painful that they would have had to prescribe it for me. Was that just something they did to go ahead and get extra money?
No, I would hope not.
Or was it just a medical error?
So the question is, the young lady to my right here was diagnosed with whooping cough, which is caused by a bug called Bordetella pertussis. And there's been a reemergence of this infection in Philadelphia in recent years. Opioids, these medicines that I have up on the screen, do suppress our natural cough reflex, which is why if you've ever had cough syrup, you might see that one of the ingredients in that is called codeine. Codeine is an opioid, just like morphine, right? And these other medicines. It's something that I don't use. I don't use codeine because we all metabolize, we all break down codeine very differently. Everybody in this room breaks it down very differently. So if I give the same dose of codeine to everybody in the room, half of you might have a very strong, robust effect and feel really good and maybe get a little sleepy, a little sedated. Yeah. Others might say, this isn't working at all. So it's very variable in terms of how it affects people. So I imagine, I don't know the specifics of your care over at Mercy, but I imagine they were utilizing this medicine to try to help with any pain you were having and also try to help with maybe that cough reflex. Because
They told me it was to keep my cough away.
Yeah.
I still coughed when I was awake. And then when I left and I was given to take it 3 times, they only given it to me once in the hospital. And
Yeah.
I'm like, this is doing nothing.
Yeah, it's, I'm not really sure, but these medicines do suppress your cough reflex. I did not include a bullet point at the end of the slide, but I want to talk about it, just in terms of the risks, because we talk a lot about the risks of these medicines and the dangers of these medicines. Again, when used thoughtfully, they can actually be relatively safe. If you take too much of these medicines, they can cause sedation, lethargy, falling asleep, which can increase the risk of bad things happening, can lower your respiratory rate and cause you to stop breathing, things like that. These are on higher doses, so when people have never seen these medicines before, you'll hear me talk about it, my mantra, start low, go slow. Talk about using the lowest possible dose that we can, and we see how you do. But those are the biggest risks. There's also a risk of very, very high doses that we use in some folks of having things like seizures and bad stuff like that. But I don't want to scare anybody away. I mean, these can be scary medicines, what we see in the newspaper and on the news. But at the same time, I want you to know that if you're seeing someone who's well-trained in handling these medicines and working with folks and taking these medicines, that can be a much safer situation. Sorry, I caught you mid-bite, sorry.
Why is it like when it's gonna rain, like my body feels like
Yeah, I know where you're going, yeah.
it's terrible.
This is so common. So the question is about when it's going to rain and the weather changes and arthritic type pain. To my understanding of the literature, I think that this is an unknown phenomenon as to actually why it happens. I cannot tell you why it happens, but it's an absolutely true.
We can predict it.
Right? I mean, forget Glenn Hurricane Schwartz. I mean, you guys know if it's going to rain or not. So, so I cannot tell you physiologically why it happens, but you're spot on. It happens, and I'm sorry it happens to you.
I was in emergency room on Tuesday when when the water was coming, because my toothache was killing me.
Oh, goodness.
I could not take it.
Oh, it's a sunny day. Well, it kind of looks like it might rain now. I don't know. What do you think? No. Oh, I'm sorry that happened. Question in the back, yes.
So there's a rumor that I've heard a lot of times, and I'm curious your
Rumor.
experience on.
Okay.
Which is that, you know, with the whole opiate crisis, doctors are often more reluctant to prescribe painkillers
Yeah.
for certain populations.
Yeah.
And that doesn't seem to be, or there's almost like the opposite effect that when it comes to older adults, that kind of like, what's the harm if they get addicted? And do you feel like, I don't know, I'm just.
So that's a really interesting question. The question is about, has the needle swung too far?
Anyhow,
Yeah.
sort of.
Has the needle swung too far in the other direction in terms of not helping folks with really bad pain who might need these medicines? And the piggyback to that question was, in older adults, is there a sense out there of it's okay if they get addicted to these medicines because they're older and so the first question I would say I do worry about the needle swinging a little too far in the other direction. I take care of, again, very, very frail, sick patients, a lot of whom have metastatic cancer, bad cancer, and they might go into an emergency department where they're not known and get undertreated for really bad pain crisis. That really upsets me. I understand why that's happening. Pennsylvania's made a lot of efforts on the state level in Harrisburg to try to combat this, really all states. So if you're not living in Pennsylvania, I mean, this is the same everywhere. So I do worry about that. To the other point, I haven't had that experience in the older patient population of saying, it's okay. You know, I seen 90-year-olds who are on these medicines and I don't really love the way that they look. They look kind of, I wouldn't do this, you know. But I have seen that. But it's not something that I've heard talked about in the community. Interesting question, though. Thank you. Question back here.
Yes, my grandson is 11, right?
Lovely.
And they got him on all this medicine.
Okay.
And he's like this, because he's hypertension.
Okay.
And they got him on all this, I don't know what kind of medicine. So when he don't take his medicine, he throw things, he wanna break things, he wanna curse his mom and dad out, he wanna slam the doors. Cause he cursed me out one day. And you know, grandma.
That doesn't fly with grandma, no. No.
I went back to the old time.
Okay.
I ain't gonna switch, I got a belt. And like, he's taking all this medicine, and when he take it, he's okay. But I told my son and the mom that they need to start letting him take their medicine at the age of 11. Because something might be going on with him, and I told him that he might need therapists and all that, and counseling.
Well, so thank you for the comment about your grandson. I don't know the specifics of his care, but it's an excellent point that you bring up, something that I alluded to in the beginning of the talk. How does emotional well-being influence physical well-being, right? So if you feel like you're dealing with anxiety, depression, your mood doesn't feel right, and you're having chronic pain, actually regardless if you're having pain or not, these are things that I encourage you to talk to your healthcare professional about because it's so important. Mind and body and how those two interplay, right? So thank you for sharing that comment. I want to talk about two more things in the last 5 minutes I have. Okay. Other medicines that we use. Some of these examples we often use in folks for issues with their mood. Medications like Cymbalta, Effexor, Elavil. These are medicines that can also, while they are helpful for mood, can also help folks with chronic pain. They work on the chemical signals in our brain. Things like substance P, bradykinin, norepinephrine, all these fancy chemicals that you don't have to worry about, that I have to worry about. But sometimes they can help people. And usually we recommend you take these for at least 4 to 6 weeks before we start to see any improvement in your pain. So I have some folks that take 2 doses of this and they say, Doc, I stopped taking it. Didn't work. I say, well, we need to give it a try. Medical cannabis. I had to put this in. So in the 2 minutes we have, medical cannabis is legal in Pennsylvania, New Jersey, and Delaware, amongst many other states in the nation. In order to be approved for this, you must be certified by a healthcare professional who is registered with the state. If you're a Pennsylvania resident, you must get certified in Pennsylvania. If you're a Delaware resident, you must get certified in Delaware. You see where I'm going. In terms of who qualifies, at least in Pennsylvania, the Commonwealth recognizes about a dozen conditions that if you have it and you were to see a professional in the office who is certified, they can say, yes, this person has a condition on the list. That's all we say. Other than that, we're separated from it in the state. We can't really study cannabis well because the DEA and the federal government considers this a Schedule I drug, which they say has no medicinal purpose. We're doing our best to study it here at Jefferson. We've really had a lot of pushes to study cannabis here. And I will say, anecdotally, I see many folks in my clinic whom we recommend, or I should say we certify them for cannabis. They try it and they say, Doc, it's really helping me. This is something that's out there. After the talk, if you have questions about this, I'm happy to go offline since we're running out of time and just chat about this on the side. But I wanted to include a slide just because it's out there. Finally, those things that are more invasive, if all of these things fail and we're not sure what to do, you may end up seeing a specialist, somebody like a surgeon to maybe do surgery to see if that might help your pain depending on what it is. Things like injections, acupuncture, mindfulness, being aware of your breathing, being aware of your heart rate, being aware of your body, right? Taking a moment to just meditate, be within yourself. That can be very helpful. This is evidence-based stuff. Read up on mindfulness. I don't know if there's any articles on mindfulness. I'd be happy to share some articles with David to share with the group at a later time, but these are all things that you can think about. So I want to thank you all again for your attention, for your really thoughtful questions. You've been an excellent group. I really appreciate you being here with me today. We are out of time, so I'm happy to stick around afterwards and answer any questions you have. But thank you again. Really appreciate being here.